And today I wanted to talk to you a little bit about the new AAP periodontal classifications. In 2017, they met and they came up with these new classifications. And what do the AAP classifications do before we talk about the changes is that they help us communicate findings to other professionals. For example, if we need to give a referral, they help the patient understand their disease and they formulate a diagnosis and treatment plan. And they also help us predict prognosis. So what happened was the American Academy of Periodontology and the European Federation of Periodontology, they released these new guidelines in 2018, and they actually met in 2017 to review these and decide if they needed to change them, and they did. And they broke out into a lot of different sessions, and a lot of different people reviewed a lot of research for us, and they came up with the information that I'm going to share with you today. I should also let you know that I've been to and listened to about 6 presentations on this, and every single one of them I felt like wasn't really oriented towards the dental hygienist. And so I wanted to give you the dental hygiene version of this because honestly, we're the ones that are finding this information out with our assessments, and then we're presenting this to the dentist. And we have about 10 minutes in our appointment to get our assessment and help make a diagnosis. Not that we diagnose by any means, but help give that assessment information to the dentist so that we can jointly make the dentist can make a diagnosis. So we're the ones, I feel like, in the front line of doing this, and so it's really important that we know what the classifications are. So why did they change these? It's an attempt to align it with scientific evidence. And of course, in dentistry, we do all of our treatment based on science, and new science has come out since the last ones were created, and so they needed to align that. And it's also expected to change over time. I know that sometimes change is really hard, and you're going to look at this and you're going to think, oh my gosh, I don't know if I can do this, but I'm going to tell you that you can, and that it's important that you do, and it's expected to change again over time, so be flexible. So let's go ahead and take a little field trip on where you can find this information yourself. Everything that I've put into my slides I've found in these documentations. So let's exit out here for a second. So on perio.org, there are a bunch of documents. So if you want to read with your office the introductory paper, it gives a synopsis of all of the information that you'll need. If you have questions while I'm presenting this, or if you're like, I don't know what she's talking about there, you can also click on this one right here, and it has the complete proceedings. It's about probably more than 500 pages, but you can pick apart anything that you're confused about. They give you details on making the workshop, participants who helped make it, and they also have these downloadable guides, which you'll want to download, especially this one for your practice. This is what I'll show you in my PowerPoint. This is also another resource that you could download as well. Maybe hang it up in your operatory so that you can make reference to it. If you wanted to print it out before this, listening to this, that would also be helpful as well, so you can make your own notes. But let's say, for example, today I tell you about some information on one of the sections like periodontal health or what is plaque-induced gingival diseases. You can scroll through and you can find the PDFs and the text that they've written in each one of these. Classification and diagnosis of aggressive periodontitis. You can do your own research and read these texts. There's a lot of them, but if you're confused, that's where I want you to reference it, right from the source. So just as a reminder, in 1989, this is what the classifications looked like. I remember being an assistant for the hygienist, and I would ask her what classification is the patient, and she would have me write AP or JP, which is, juvenile periodontitis, adult periodontitis. And then in 1999, they came up with this classification system where we have 1, 2, 3, 4, 5, 6, 7, 8, and you said the patient either had gingival diseases, they had chronic perio, they had aggressive perio, and so forth. These were the individual descriptions of each one of those. So there was gingival diseases, and it gave you a synopsis of all the types of gingival diseases that there are. These are the old ones. So I know that these are a little bit hard to see, but I'm just reviewing with you, just refresh your memory what the old ones are. So this is what the new ones look like. We have an area what's called periodontal health, gingival diseases and conditions, and it gives 3 different descriptions, which we'll talk about. Periodontitis, 3 different descriptors as well. Conditions that affect the periodontium. And then they gave us a new category, perio, implant diseases and conditions, and 4 different categories there, which we'll go over. This is also on their website. I color-coded it just a little bit differently, but these are just a little bit more of the descriptions. There's, 4 different categories. It just shows it in a different manner than this one. So let's first talk about periodontal health, gingival diseases, and conditions. This really didn't change. So what we're going to use this information over here for is we're going to say my patient's diagnosis is gingival health on an intact periodontium. Okay, I'm going to do a prophy. Pretty easy, right? At this conference, it was agreed that bleeding on probing should be the primary parameter to set thresholds for gingivitis. So if you go in and probe, you need to be marking your bleeding points. That will help you assess if this patient has gingivitis, moderate, localized, or advanced gingivitis. Okay, bleeding on probing in 10% or more of the sites is required for the diagnosis of dental biofilm-induced gingivitis. So if we look at this section here, if they have gingivitis and it's caused from biofilm, we can say, generalized gingivitis associated with dental biofilm alone. That has to be in at least 10% or more of the sites. Lower levels of bleeding on probing, less than 10%, are considered actually a variant of health. In fact, the term incipient gingivitis was introduced to describe this clinical presentation of diseases. But let's say, for example, there's not a lot of biofilm, but they are taking a medication that influences the drug actually causes gingival enlargement. Then that's what you would write the reason for. Generalized severe gingival inflammation due to drug-influenced conditions. So it just goes over a lot of different ones. We just don't have time to go over all of those individually, but some interesting things as well on this is that you also have clinical gingival health on a reduced periodontium. So this could be a stable periodontitis patient. So maybe they've been coming in perio maintenance for a long time. They still have bone loss, but they're stable. Or they could have reduced periodontium and be a non-periodontitis patient. So maybe those with recession. We're still going to be using our codes the same. So if we have a D1110, the gingival will be normal, or we'll have generalized local moderate inflammation, local mild inflammation, localized moderate inflammation, or even localized severe inflammation. But when you get to the D4346 code, you are making the assumption that there's, not the assumption, but you're finding that there's gingivitis generalized, a moderate amount because you're seeing redness, edema, glazing, bleeding on probing. If you have generalized severe inflammation, there's redness, edema, ulceration, tendency to spontaneously bleed. That's when you're and there's no periodontitis, there's no bone loss. That's when you're doing that D4346. When a patient has stable periodontitis, you're going to be using that 4910 periodontal maintenance code. But also along when you have a periodontitis patient, even though they're perio maintenance, you will still document their stage and grade. Once the patient has perio, they always have perio, and this is the biggest change right here that we have when it comes to the changes of this AAP classification. So you've already been pretty much doing this. So this information on gingival diseases is similar to what you've always been doing, but it allows you to write more descriptions. Make sure that you're charting bleeding on probing, and make sure you tell your patient your diagnosis. I crossed that out and said their diagnosis, because you want to remember that it's not something that you created, it's something that your patient has. So why did they do a new periodontal classification system? When the old system was based on disease severity, so we had chronic or aggressive, and that fails to capture the important dimensions of an individual's disease, including the complexity that influences approach to therapy. The risk factors that include likely outcomes and level of knowledge and training are required for managing the individual cases. Now, I really like that last line because it says the level and knowledge of training required. This is us. This is us as dental hygienists. Of course, if it's more advanced or seeing a periodontist. But you need to be trained and educated on periodontitis and treatment of that. And that's really important. Let's talk about this second section right here. This is the section that changed the most, the periodontitis section. So these are the descriptions, and these descriptions are ones that I pulled from the actual documents. They're not really written anywhere nice and easy for everyone to see, but I had to go through and pull them out of the documents. And the first section, necrotizing periodontal disease, we know what those are. Periodontitis as a manifestation of systemic diseases. These are, like if a patient has Down syndrome or lupus or leukemia, they might have periodontitis due to some of these. Obesity was also in that classification. And there's a lot of information in this section. If you want to know more about it, you can go read that section in particularly. Periodontitis, we have stage 1, 2, 3, and 4. This is the biggest change that we have. We already pretty much know these. Stage 1, initial periodontitis. Think in your mind of a patient who has initial periodontitis. It's very initial stages of bone loss, maybe 4s, some 5s possibly. Stage 2, moderate periodontitis. Stage 3, periodontitis with a potential of additional tooth loss. So this is pretty severe. They're maybe potentially losing teeth due to periodontitis, not from like an abscess or caries. It's from periodontitis. Severe periodontitis with the potential for loss of the full dentition. And then we also, with a stage, we're going to give an extent. Is it localized, generalized? This molar incisor distribution is when we were looking at like juvenile periodontitis back in the day, where it was on the molars or those incisors. And then with each stage we're going to give patients a grade, which we'll go over. So, is the periodontitis progressing at a slow rate? Is it progressing at a moderate rate? Or is it progressing at a rapid rate? So I feel like we see this all the time, and I feel like we can incorporate this pretty easily, actually, as we go through these individually. Here are the 1999 classifications. Here are the 2018 classifications. And I'll show you here in just a few minutes that you're only going to give one stage and grade per patient. So even if one tooth has severe periodontitis with additional or some other teeth to be lost, stage 3, even if it's one tooth. If they have most of their teeth are in stage 1, but they have one tooth that's in stage 2, we're going to say stage 2, even if it's one tooth. So we'll go over that more here in just a moment. Okay, why are we using staging? So the concept of staging has actually been used in oncology for a long time, determining the staging of tumors and the size and whether it's metastasized and the extent and the complexities. So there's no more, you just need a deep cleaning, you have a little bit of gum disease. Like, this is a really serious thing. I recently received a text from someone close to me that they said they were diagnosed with cancer, and they said they need to get a tissue sample of the tumor to see what grade and stage it is. So can you imagine patients actually being like, I have periodontal disease, and they need to find out what stage and grade it is, or this is my stage and grade. I'm concerned. So I really find this exciting that they have applied this to dentistry. So let's talk a little bit about how to stage a periodontitis patient. Now, this information comes directly from the perio.org, from those documents. This is not something that I've created. This is from them. So our goal is to classify an individual based on their measurable extent of destroyed and damaged tissue. And then when we assess complexity, we assess specific factors that may determine complexity of controlling current disease and managing long-term function and aesthetics of the patient's dentition. So this is the document that you're going to need in your operatory. This is very important. This is on perio.org. They have this in a printable version. You can download it, you can write on it, whatever helps you understand perio, you understand this better to write it on there. So let's read the directions here at the beginning. Staging intends to classify the severity, which is what we just read on the previous page. So I won't go through this too much more, but the second part of this says, the initial stage should be determined using clinical attachment loss. Now I might make a note here and maybe put an addition that says determining interdental clinical attachment loss instead of just clinical attachment loss, because a lot of times we just think, oh, recession, but actually this is interproximal clinical attachment loss. If CAL is not available, well, you might be thinking, why isn't CAL available? I'll tell you why here in just a bit. Then radiographic bone loss should be used. Tooth loss due to periodontitis may modify stage definition. So that's when we're over here, those descriptions we saw earlier with severe, with tooth loss, or with all teeth loss. One or more complexity factors may shift the stage to a higher level. So if generalized the mouth is in stage 1, but you have one tooth that is at a moderate stage, that is going to shift you up to the next level. Let's also blow just up this section right here and look at it a little bit closer with some of the descriptors. So our clinical application to this is, when am I doing 4341? I have my stage, maybe I'm stage 1, and if it's on more than 4 teeth, then I can do 4341 per every quad. If it's on 1 tooth, 1 to 3 teeth in each tooth, I'm doing 4342. And you're going to also need to document if it's generalized or localized, for insurance purposes. But just a reminder here, we have initial, moderate, stage 3 is severe tooth loss, stage 4 is severe with all teeth loss. If we're looking at these pocket depths, this area has that less than or equal to 4 millimeters. And if there's just 4 millimeter pockets and no bone loss, then we're back to gingivitis. And we're doing a 4346 or an 1110, depending on the severity of their gingivitis. But if there is bone loss within that coronal third, we're at initial. Somebody asked once recently, what about if they have a 5 millimeter pocket, but it's a pseudopocket and there's gingival overgrowth? Then no, you do not diagnose stage 2 moderate periodontitis. That is a pseudopocket, and that is still within the level of gingivitis. So this has to be a 5 millimeter or less pocket with horizontal bone loss, mostly horizontal bone loss. So they say there might be maybe some beginning stages of vertical bone loss. Once it gets greater than or equal to 3, that's when we're putting it in the stage 3 or stage 4 category in that vertical bone loss area. Remember too that when we're also putting if it's generalized or localized stage 1, 2, 3, or 4, generalized is if they have 8 teeth within a normal 28 teeth mouth dentition. Okay. Let's look at another section. Let's look at some of the details of the radiographic bone loss. So we're at stage 1 when you see cupping, triangulation, fuzziness, loss of the lamina in that coronal 15%. We're at stage 2 when we're within the coronal 33%. And then we're at stage 3 and 4 when we're at that middle third and beyond. When we have so much bone loss, we're at stage 3 and 4. So keep that in mind. That's what bone loss is looking like on your radiographs. And I know that there are limitations to these, but that's what we have at this point to work with. Let's now talk about this interdental clinical attachment loss, interdental. And this is going to be the greatest side of loss. So our stage 1 is when we have 1 to 2 millimeters. Stage 2 is 3 to 4. Stage 3 and 4 are greater than 5 millimeters. And then we'll up that stage depending on some of those other factors. So why do we use CAL? Well, our probe depth is a measurement from the margin to the junctional epithelium, but our clinical attachment level is the measurement from the CEJ to the junctional epithelium, which is a little bit more of an accurate indicator of periodontal support because the CEJ doesn't move like the gingival margin does at times based on if it's inflamed or not. So it's more from a fixed point. And it's a little bit ahead of its time. The textbook does say you can measure clinical attachment loss, but that takes a little bit more time than our probe depths. They're actually having people start doing this on REB. You have to determine where the CEJ is, and you have to measure how much tissue is above that CEJ and then do some math, some backwards math. For example, let's say, oh, we found a 9 millimeter pocket. Okay, well, 6 millimeters of that is below the CEJ. So we'd feel where's the CEJ and we'd measure up from there. We say, okay, there's 3 millimeters above the CEJ. So our actual clinical attachment loss is at 6, which does put us in a stage 3 or 4. Here's some charting examples. This is Dentrix, but there's a ton of different, of course, computer systems out there that do this for us. But our pocket depth here on number 10 is 212. And in Dentrix, for example, they automatically take our clinical attachment level and they count it as 212. Which, that's questionable because that puts me in stage 1 to 2. Well, that doesn't seem right. Interproximally, do I really have periodontitis? This is a healthy patient, 212. But that's because we need to measure the true clinical attachment level. So, for example, on the tooth next door right here, what I've done is I've said, okay, my gingival margin is actually 2 plus. I hit my 2 plus in Dentrix, 2 plus. Is 2 millimeters above the CEJ, so my clinical attachment level is actually 0, 0, 0, which is health. So doing that on every single patient, finding how many millimeters is above the CEJ, is going to be a time challenge for us as hygienists. Very much so. So we might have to, if we feel like it's health, we might just have to ignore some of these numbers depending on the charting system you're using and say, well, that's within health, and then actually take actual more thorough measurements of those that need to be measured correctly. Like in this sample right here, if you find a 9 millimeter pocket, we need to find how, the true level of loss, how much gingival overgrowth do I have to be determining what stage my patient is actually in. Okay, here's another example. I have a probe depth of 2 millimeters. It's right at the CEJ, right where it should be. It's health. So the gingiva is 2 millimeters above the CEJ, so I have a clinical attachment loss of 0. Everything's fine on that tooth. Okay, here's some more examples that might help us determine. We're not looking at the facial aspects. Okay, it is only interproximal cal. So for example, in Dentrix, if I have a 4, 3, 7 pocket depth, I need to go in and determine from the CEJ up to the margin. So I might, or if there's recession. So in this example right here, there's 1 millimeter of recession interproximal, so my clinical attachment level is at 5. Over here, however, I have a 7 millimeter pocket. Then I take my probe and I feel where the CEJ is, and I measure up to the gingival margin, and that's 3 millimeters. So 7 minus 4, or 7 minus 3 is 4. So my clinical attachment level, if it was just that one area on that tooth and everywhere else was healthy, a 4 puts me at the stage 2 category. Okay, we know on these ones that 8 and 8, that's going to put us stage 3 and 4. If over here we have a 2 and a 1, then that's going to put us in stage 1, if it's just on that particular tooth. So that might be a challenge for hygienists to determine interdental cal. It's going to take a little bit more time to determine that. Here's some more examples. Sorry for my unfortunate, beautiful art that you get to look at here, but it does give us a good baseline for some samples here. We have a probe depth of 5. There's no recession, and the margin is right at the CEJ. So we can say our clinical attachment level there is 5. Okay, that puts us in stage 3 or 4. We have to determine how much bone loss there is and some of those other factors before we give that a final stage. Then, let's do another example here. If we have a probe depth of 6 total, and then we find that the gingival margin is 2 millimeters above the CEJ, 6 minus 2 is 4. So we have a clinical attachment level of 4. If it's just that one tooth in the mouth, we're saying localized stage 2. If we find that on 8 or more teeth in the mouth, localized stage or generalized stage 2 is what we'd put. Here's another example. We have our probe depth of 4 millimeters. Then we have recession. So you can see the margin is clear down here. We have exposed root surface. So our clinical attachment level is pretty far down here at 7 millimeters. That's putting us in approximately, once again, not facially, at stage 3 or 4. Okay, also there's this other category. If there's no tooth loss due to periodontitis, stage 1 or 2. If we do have bone loss and tooth loss, and we can determine that tooth loss was from periodontitis, not from caries, then we can put them maybe more in these stages. Like I said again, we don't see a lot of patients with a lot, in a normal standard private practice with these. Probably if you're working for a periodontist, or maybe at like a community clinic, you might see more patients that have these conditions. And then just once again down here, you're going to add those descriptors for each stage. So the extent, is it localized, generalized? It has to involve a certain amount of teeth, right? Okay, staging is not flexible. The documents say it can go up, but not back down. So once they're a 1, they're always a 1. It shouldn't go back down. A periodontitis patient is a periodontitis patient for life. Once they get put on perio, they're on perio maintenance for the rest of their life. Do not go back down to a prophy. That is a prevention of periodontitis code. Okay, why are we using grading now? We've learned how to stage our patients. Now let's learn how to give them a grade. And grading helps us estimate future risk. Are they at risk for future tooth loss or progression of the disease, or are they doing pretty good? So here's grading. This piece of paper also comes from perio.org. We did not create this on Hygiene Edge. And I would recommend that you print it out, write on it to determine your patient's grading. So we're going to say, okay, I'm done with my assessment. I've determined that you have periodontitis. We rank it from stage 1 to 4. You're at stage 4. And then we also give you a grade on how well you're doing with preventing it from progressing. A is you're doing awesome. B is you could do better. And C, I'm concerned. And you're at the level C because you smoke a half a pack a day, or whatever it is. Or you're doing awesome because you have very little biofilm, you're not smoking, or you quit smoking. I'm going to put you in the A category. So that's how it's going to sound to your patients. So this is what it's going to look like. Let's talk about how we give each one of these patients a grade. So clinicians should initially assume B. Everybody could probably be doing better. And then let's seek evidence to either shift to I'm concerned, or A, you're doing awesome. I just made those up myself. The easiest way to determine this for me, grade, is to look first at their cigarette use, nicotine use, smoking. This is only smoking real cigarette. This is not vaping or marijuana use. But if they smoke a half a pack a day, that's 10 cigarettes. You're automatically concerned. If they smoke 9 or less, they're at a B category. If they're a non-smoker, we're thinking, okay, they may be in the A category. It's probably the quickest way to determine grading. You could also be determining that based on their HbA1c for diabetes. That's also another category that you could use. And then I personally go up from there. This is just the quickest way for me to determine it, because most patients have perio. Usually it's because of some systemic problem from smoking. So let's go ahead and let's look at some of these. In particular, we have to do some math to determine their grading. If we don't know the information about their smoking, we're going to have to do a little bit of math on the bone. So let's talk about how to do that. Okay, let's look at this first line right here. This might be hard to tell. This might be a patient, if they're a patient of record who's been coming for years, then you can get direct evidence of progression. So you could see if there's bone loss, radiographic bone loss. There's none over 5 years, A. Less than 2 millimeters over 5 years, B. Or greater than 2 millimeters, a C. That's hard to tell if they haven't been a patient of record the whole 5 years. So the best way to indicate is by doing a little bit of math. What you're going to do is divide the bone loss by their age. So some examples of this is if they have 33% bone loss, say this is even on one tooth. You're just going to take the greatest tooth. Divide that by their age, 40. That comes out to 0.83, which puts them in a grade B. Okay, 15% bone loss at age 80. That's 0.18%. They're doing pretty good for their age, grade A. If they have 33% bone loss by age 25, this is of concern, 1.25. We're at a C. So you're going to have to get a calculator in your operatory to be able to determine sometimes their grading. If they smoke, that's an easier way to do it. But if not, then you're going to have to determine if they smoke a half a day, it's easy to determine that. But if not, then you're going to have to get your calculator out. I guess that's what I'm trying to say here. Our clinical application is document their stage and their grade, and tell their patients what their stage and grade is. You have periodontitis. We stage it from 1 to 4. You're at stage 2. and you're actually doing pretty good, or you could be doing better, or C, I'm concerned because you smoke a half a pack a day. Let's talk about some cessation. Let's talk about getting a referral to your physician for that. Or let's talk about getting your HbA1c number under control, things like that. Okay, insurance coverage. The classification will not reinfect reimbursement. Reimbursement at this time, insurance companies do not reimburse based on severity of disease. If it's a 1, 2, 3, or 4, but that could change over time, they say. So let's look at this third category, periodontal manifestations of systemic diseases. This is a little bit of an easier category to digest. We haven't had to learn anything new like we did in this periodontitis section. Mainly this section is there. The new classifications lists conditions that also include systemic diseases and conditions that affect the supporting tissues. So they just mainly say that these allow us to give early diagnosis of the disease and contribute to an improvement of the management of periodontal manifestations. So they could have these issues, or they could have periodontitis based on occlusal trauma. We would still give them a stage and grade. Or they could have a stage 4, a stage 3 periodontitis because of an abscess. We're still going to give them a stage and a grade. So this just gives us a little more resources to give an early diagnosis as to why they might have periodontitis. Okay, the clinical applications there once again. Stage 3, grade A periodontitis due to a periodontal abscess, or orthodontic forces, or primary occlusal trauma, things like that. So we'll help use this in our dental hygiene diagnosis, but nothing really big has changed in this category that we need to implement too much. So our last category is peri-implant health, and there are 4 categories. So patients are having more and more implants, and we need to make a protocol as an office on how to treat those. And then we also need to be giving them a category of their condition. So you can either say they're in health, there's no inflammation, there's no bone loss. Or they have peri-implant mucositis, which is an inflammatory lesion of the soft tissues only. There's absence of bone loss, so no bone loss. Peri-implantitis is that there is loss of bone, and then there might be perio-implant soft and hard tissue deficiencies due to, cement or the healing or, a lot of different factors. Something stuck down in there or trauma. So you're going to give a statement on each implant that's in the patient's mouth. You should now start giving a statement on implant health. Develop a policy with your office, classify them underneath the new guidelines, and put that in your notes or clinical applications there. If you remember from school, ADA case type, different from the AAP case type, this is mainly used for insurance. So type 1 is with gingivitis only, type 2 is slight periodontitis, type 3 is moderate, type 4 is severe. So I still write down my ADA classification in my notes for insurance purposes, but now I'm adding on these new AAP classifications as well. Case type, this is what the book says about case type, which are these ones. They're only to be used as supplemental description for insurance purposes. So keep that in mind. We're mainly using the AAP classification system to determine the level of periodontitis. Okay, how do I incorporate this into my practice? Shelley, you've told me this information. What do I do with it? Have a meeting with a dentist and go over the new how to classify, stage, and grade patients with periodontitis. Everything else pretty much, we could say that it stayed the same. But hey, doctor, when I diagnose perio, or when you diagnose perio, when a patient has perio, we need to give them a stage and a grade. And they need to know it before they leave. Okay, have the documents. Go on the perio.org. Print those out for your office. They're a great resource. Write on them, implement them. Start maybe with 1 patient per day and use your cheat sheet and just try 1 patient per day and then build up to that as you practice that. Maybe do some case studies in your own office, maybe in a staff meeting or hygiene meeting. And then start telling your patients their diagnosis. It's no longer, you have a little bit of perio, we need to do a deeper cleaning. It's you have periodontitis, the stage is 2. We need to do a therapy on your gums where we go in and we clean out the bacteria and the biofilm so that this can not progress. Okay, the documentation also provided us some other new guidelines They determined that there's a very small cohort of women who are extremely sensitive to hormonal changes during their menstrual cycle, but most women don't have it. There's no detectable signs. And then also contraceptives are much lower than original doses that were reported earlier, and it's known that current formulations of oral contraceptives do not include the clinical changes of the gingiva that were reported with high-dose contraceptives. So if you see gingivitis, we're not always just blaming it on their menstrual cycle or their birth control. So keep that in mind. There's usually other reasons. Okay, also it helped us, they still haven't determined, there's no existing data to provide solid evidence to substantiate the effect of occlusal forces on abfractions or gingival recession. So more research needs to be done on what the actual cause of recession and abfractions are. Also, there's some new terminology. Instead of calling it occlusal force, it's called traumatic occlusal force. And then this picture here is biological width, what has been replaced with supracrestal attached tissue. That's the new terminology. No more biological width. It's called supracrestal attached tissue. Biological width is from the top of the bone to the epithelial attachment. And then they also gave us new recession classifications. So recession type 1, 2, and 3. 1 is there's no loss of interproximal attachment loss. Interproximal CJ is clinically not detectable. Recession type 2 is there's recession associated with loss of interproximal attachment. And 3 is loss of interproximal attachment. And the amount of interproximal attachment loss is higher than the buccal attachment loss. So if you see this on a patient, you might say, how much they have and then give them a recession type. You could implement that into your practice if that's something that you and your dentist choose to do. And then there's my resources page. But mainly that perio.org site is super helpful in determining what you need to apply to your practice. And I hope that that was helpful to you. And I hope that you go out and you start staging and grading in your practice. Best of luck.